Today we have doctors from the newest Scleroderma Research and Treatment Center at National. Dr. Maleki is an associate professor in the Division of Rheumatology. She received her medical degree at Isfahan University of Medical Sciences, and she completed her internal medicine residency at Michigan State. She's also a research fellow at the Chronic Pain and Fatigue Research Center. Dr. Maleki completed her rheumatology fellowship at the University of North Carolina, Chapel Hill. Dr. Kastsianok is also with us today, and she graduated from the Belarusian State University Medical School and finished her internal medicine residency at the St. Mary's Health Center, affiliated with St. Louis University. She also completed her rheumatology fellowship at Washington University in St. Louis. And one last disclaimer before we get started from the Scleroderma Foundation. The Scleroderma Foundation in no way endorses any clinical trials, treatments, or studies mentioned in this session. Because of the manifestations and severity of scleroderma, they vary among individuals. Personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with your individual doctor. This webinar is for educational purposes only. And without further ado, please take it away, ladies.
Thank you, Maria.
So hello, sorry we are wearing masks because we are sitting beside each other. So just to follow the recommendation for COVID-19. So I'm Mehrnaz Maleki Fischbach from National Jewish Health and Scleroderma Program. And
my name is Liudmila Kastsianok, National Jewish Health Scleroderma Program. So we would like to start.
So some of these slides can be redundant because we are the last sessions, but it's okay to go over them, I guess. So the type of systemic sclerosis include scleroderma, scleroderma. That means they have internal organ involvement without any skin manifestation. Limited cutaneous systemic sclerosis, which formerly was known as CREST syndrome, which stands for calcinosis. Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. Diffuse cutaneous, that is involvement over elbows and knees, face, and trunk. And scleroderma overlap syndrome, which is overlap with other conditions in rheumatology like rheumatoid arthritis, myositis, systemic lupus erythematosus, and Sjogren's syndrome.
The main manifestation of systemic sclerosis include fatigue, which can occur very early at the course of the disease. Joints can become achy and stiff with morning stiffness and inability to use hands lasting up to 60 minutes or even above. Loss of strength in the muscles and hand grip, loss of strength in the joints, pain in the muscles and joints, difficulties with sleeping because of the chronic pain, because of the chronic itching from the skin involvement, and skin discoloration, which we will talk about a little bit further down.
So here we have different manifestations and some pictures. So itching and edema is very common, especially in the earlier stages of skin involvement. As you can see, they can have hypopigmentation and hyperpigmentation. They call it salt and pepper, loss of hair, dry skin, telangiectasias. They can have lipoatrophy, which means that the fat under the skin kind of melts away and they have an indentation. Sclerodactyly, which is thickening of the skin of the digits, and diffuse sclerosis we mentioned above elbow, above knee, face, trunk, back, and for research purposes, normally they count modified Raynaud score system over 15. They can have digital tip ulcers, pitting, and calcinosis cutis, which is, as you can see, the calcium deposit kind of piercing through the skin, and sometimes it causes ulceration.
The vascular involvement of scleroderma, majority of the patient, if not all, have Raynaud's phenomenon. Usually it's present at the onset of the disease. Sometimes it can develop within the 1 or 2 years of the disease onset. The hallmark of the Raynaud's phenomenon include fingertip color changes when someone feels cold or touches something cold. And the color changes can go from white, purple, red, with subsequent extreme tingling and numbness in the fingers, and gangrene or necrosis, dark discoloration of the fingertips can develop. Usually, patient with long-standing Raynaud's phenomenon can develop abnormal capillaroscopy exam, meaning when we look at the nail beds of the fingers, we can see some changes, and these changes can manifest in early stage, just slight thickening of the capillary loops. Later in the disease, hemorrhages can develop or bleeding within the nail beds. Later in the disease, dropouts in the nail beds architecture can develop with neurovascularization or new capillaries formation. Usually when we see such changes of the, on capillaroscopy exam, the patients have higher chance of developing elevated pressure at the pulmonary artery and pulmonary hypertension. Patients with scleroderma also have increased risk for venous thromboembolism.
So muscle involvement, musculoskeletal involvement can include tendons, joints, bones, and inflammation of the joints. So one of the early findings in diffuse cutaneous systemic sclerosis is tendon friction rub. So technically it's like a palpation of leathery sound kind of sensation, which can happen with the movement of like elbows, wrists, and normally this is associated with poorer prognosis. We will elaborate on that a bit later. Joint pain, it can be pain as well as arthritis. By arthritis, we mean inflammation, synovitis, which is lining of the synovium, and then contracture, when the skin gets so tight and it's not movable, that also can cause pain. As you can see in this X-ray, acroosteolysis is an X-ray finding. So as you can see, the tip of the fingers is kind of has bone absorption, and sometimes you can see it even, without any X-ray, that the digits are getting shorter, especially in the distal, the end of the fingers. They can have inflammatory arthritis we talked about, like synovitis, and that's normally uncommon, but it can be seen.
Another musculoskeletal involvement includes involvement of the muscle, and muscle involvement can occur with muscle atrophy, muscle weakness, inflammation in the muscles, with elevated muscle enzymes due to diffuse skin sclerosis.
So again, we are talking about the true arthritis. That means inflammation of the joints, but it can happen in a couple of joints, or sometimes that can be widespread. It's more common when there is an overlap disease, especially with rheumatoid arthritis, with positive antibodies for rheumatoid arthritis, which is anti-CCP. They can have occasionally erosive disease, which means the bones are having holes in them, which is the beginning of deformity. It normally spares the distal knuckles, so normally it's in these joints and these joints. They can have, we can get the fluid out of the joints, and it can have mild inflammation, so it may not be as inflammatory as rheumatoid arthritis. And we mentioned tendon friction rub, and it's normally a sign that it's a more aggressive disease. It has more organ involvement, and also it can be associated with renal crisis, which now we see rarely, but it still is a very concerning consequence.
There have been a recent study published at the Journal of Medicine, the study from China, And this study looked at the patient retrospectively who have systemic sclerosis, and they look at the muscle involvement. Study found that the patients with muscle involvement are more likely to have diffuse skin involvement with scleroderma. They are more likely to have lung disease, gastrointestinal or digestive system involvement, more likely to have pulmonary hypertension and fluid around their heart. This patient with muscle involvement had high disease activity score and severe clinical manifestation of systemic sclerosis compared to those who did not have muscle involvement. So the study concluded that muscle involvement with systemic sclerosis associated with the worst prognosis. I would like to talk about patient of my musculoskeletal ultrasound. We have this opportunity at the National Jewish Health to provide that diagnostic tool for patients with scleroderma and other rheumatologic diseases. So musculoskeletal ultrasound, why it can be helpful in patients with scleroderma. Because of the skin thickening, joint contractures, and joint deformities, patient can have chronic joint pain. This joint pain can be hallmark of the inflammatory arthritis as well. When we look at this joint with the ultrasound, we can see if there is inflammation of the lining of the joint, and our management or treatment recommendation might little bit differ. It's also very helpful to use musculoskeletal ultrasound to evaluate for erosions or damage within the joint. Also helpful to see if patient have some kind of bumps or growth, to see is there ganglion cyst, is there calcification or calcinosis from the scleroderma. It's also helpful to evaluate for tendon pathology. Is there just diseased thickened tendon, or is there inflammation surrounding the tendon?
So just to elaborate on that, I'm very happy that Mila joined us, because for patients with systemic sclerosis, their skin is so tight. Normally, we rheumatologists use our fingers to check synovium. And for patients with sclerodactyly or diffuse cutaneous, it's really hard. So we cannot really rely on our finger to say, oh, you don't have inflammation.
Thank you, Mehrnaz. And I just want to share a few pictures how it can be helpful in diagnosing and evaluating patients with scleroderma. The first picture you can see, this is the joint, one of the hand joint, and you can see the tendon running in there. And on top with the arrowheads, there is gross calcification, calcinosis underneath. So when I see a patient in the musculoskeletal ultrasound clinic and then complain pain in this area, put an ultrasound probe on top of this joint and see is there swelling, is there swelling in the joints, swelling with fluid, or is there calcification. It's very helpful. The second picture shows the small hand joint with distended joint capsule and lining of the joint, which is enlarged, representing inflammation. The bottom picture shows the tendon, and tendon surrounded by the dark fluid, which we call tenosynovitis, basically inflammation of the tendon, which is a sign of inflammatory arthritis. What are the benefits of musculoskeletal ultrasound versus MRI? Musculoskeletal ultrasound, it's very easy, tolerable by patient. Multiple joints can be scanned at the same session. Comparing with MRI, you only can get pre-approval for one hand or one knee at the same time. You don't need to use contrast, and some patients who have underlying chronic renal disease cannot have contrast. Patients who are claustrophobic, they might not be able to tolerate MRI, and musculoskeletal ultrasound much better tolerated. So there is a lot of pluses. And another thing, when they compared musculoskeletal ultrasound to MRI, the outcome in diagnosing joint and tendon pathology, basically the same.
I mean, many of my patients are not really looking forward to be in an MRI machine, so I think this is really easier for patient, especially if you have contracture and you have trouble breathing. So I think that's really wonderful.
Yep.
So let's talk about treatment. We just touched base on it a little bit. So as you mentioned in previous session, localized scleroderma is more common in children. But it can be seen in any ages. There are some topical treatments as well as other treatments. So topical is tacrolimus, is an immunosuppressive medication. Then we can use topical corticosteroid or injection that dermatologists do in the lesions of sclerosis. Topical vitamin D works. In general, for patients with systemic sclerosis, we also want them to have normal level of vitamin D. And then there is a medication called imiquimod. You said they can be used in wart as well. These are normally prescribed by our dermatology colleagues, as well as phototherapy that can be done with them, by them. There are some surgical intervention that can happen too, which again, the dermatologists normally do that. One of the most common and annoying manifestation of systemic sclerosis is itching. Of course, antihistamines can be used. Not sure how much they can help, to some degree apparently. Skin lubrication is better to use like lotions that they don't have perfume in them, and they're very gentle, like Cetaphil, CeraVe, and all those very gentle skin lubricants. They also can use capsaicin or menthol that also can help with the joint manifestation, and low dose of prednisone if the pruritus is really bad. I actually have a patient that has overlap of systemic sclerosis and myositis, and we tried everything, and somehow that 5 milligram of prednisone helps a lot, and now she decreased it to 3 milligram, and she's doing quite well in regards to itching. So treatment of calcinosis cutis. So another very annoying manifestation of skin manifestation of systemic sclerosis. So it can cause ulceration, as we saw in the picture, infection. There are several antibiotics can be used, but minocycline is recommended. We normally use it for 6 to 12 weeks. There are some case reports that we can use warfarin, diltiazem. We actually use it for Raynaud's anyway. Bisphosphonate, which is a medication for osteoporosis or osteopenia, thin bones. IVIG, colchicine. I actually have used colchicine and bisphosphonate with some degree of improvement. What about you, Mila?
So I use colchicine, diltiazem, a few times bisphosphonates, and once minocycline. Again, calcinosis is such a challenging manifestation, very difficult to treat. With colchicine, I found there might be issue with tolerability from the gastrointestinal standpoint.
Yeah. And then if it gets really bad, if it's like poking through a skin, it's cause infection, we can use surgical intervention, can be done by some dermatologists, or if it's near joints and tendon, by orthopedic surgeons, which can be quite helpful when nothing else helps.
So for the Raynaud phenomenon treatment, the number one that we recommend to everyone, lifestyle modification. We cannot emphasize how important is that. Make sure keeping the core temperature of your body warm, wearing gloves with colder weather, wearing socks, no flip-flops for the clinic visits. And in winter, it's very important to cover your ears and cover your nose, because when you cold in your ears and your head, it can trigger the Raynauds in the hands. A lot of patients, they use leg warmers or arm warmers to put in the glove, which are very effective.
Warmers, yeah.
Exactly. So for the medication treatment, Usually to go number one, we go to calcium channel blockers such as diltiazem, amlodipine. Medications such as sildenafil or Viagra can be used. Other medication that used to treat pulmonary hypertension also can be helpful for the Raynaud phenomenon, and it includes iloprost, IV opioid, bazentan. Also, topical nitroglycerin can be used sparingly. There is also some reports of using some antidepressant medication for Raynaud phenomenon. Mehrnaz, remember you were sharing that story?
So I have a patient with diffuse cutaneous systemic sclerosis with very bad systemic sclerosis. She didn't have pulmonary hypertension. Sildenafil was working to some degree. I'm a huge fan of topical nitroglycerin when there is ulceration because it helps the circulation. But long story short, she was depressed and her primary care placed her on fluoxetine, and the Raynaud's in combination with other medication almost dissolved. So that was something I shared with my colleagues that maybe we should give it a try more
frequently. Yep. So, and for the surgical, there is potential for surgical treatment for Raynaud's phenomenon. Again, very mixed results in the randomized control trial. Digital sympathectomy can be done, or botulinum toxin injections. It's usually done by the orthopedic hand surgeons.
So for telangiectasias, we saw the picture. Of course, the patient who have a systemic sclerosis are very familiar with this manifestation, which is the vessels of the face or palms or even inside mouth gets dilatation. So the easy one is make up as much as possible. If it gets to the point that is, hard for the patient, we can try laser and light therapy. Again, we use our colleagues in dermatology to help us with that. We also have good medication to treat the skin. So as long as the patient doesn't have lung issues like interstitial lung disease, which is fibrosis of the lungs, we can use methotrexate. We use a lot of mycophenolate mofetil in our center, which helps if there is any concomitant organ involvement like interstitial lung disease. IVIG, there's some research that showed it can be helpful. It's hard to get approval. The same with rituximab, but if the patient has symptoms of inflammatory arthritis, like I sent patient to Milan, they said there is synovitis, I can call auto overlap with systemic sclerosis, so we can get that easier. The same with anti-interleukin 6 inhibitor like tocilizumab, Actemra, that we also use in patients mostly when they have joint pain or they cannot tolerate other medications.
So for the myopathy treatment, a lot of medication, as you see, overlap. Methotrexate can be used, again, if there is no pulmonary fibrosis or lung involvement. Azathioprine, very effective, very helpful. Mycophenolate mofetil can be used, IVIG, low dose of corticosteroid, and we refer this patient early for physical therapy and rehabilitation program to make sure they won't develop severe muscle weakness and debilitation from muscle involvement. For inflammatory arthritis, we have frequently used in our center hydroxychloroquine, very mild medication, easy, pretty easy tolerable medication. Again, methotrexate if no lung involvement. Rituximab can be used, abatacept, which one of the subcutaneous IV medication, which we frequently use in rheumatoid arthritis, tocilizumab, which is IL-6, and low dose of prednisone can be used as well.
So just to elaborate on the muscle, so it's really good if we find some other findings that it opens the door for using more medication. Imagine we want to use IVIG for the skin, but the patient has a little bit elevated muscle enzyme, so IVIG can be approved for myositis. So it's really good to look at not only the main involvement of the systemic sclerosis, but other side involvement that maybe they are not as annoying. And that way it opens the door for having more option for medication. And again, it's really good to look at the joints with ultrasound. If there's inflammatory arthritis, the doors open to abatacept, rituximab, tocilizumab. That also there's some evidence that it can help with interstitial lung disease and other manifestation of systemic sclerosis. And again, I think you mentioned that we cannot use prednisone very high in systemic, high doses in systemic sclerosis because of
the risk of scleroderma renal crisis. It's one of the, before it was very common cause of the early death from systemic sclerosis. Right now, we've learned how to early recognize, and the number of scleroderma renal crisis goes significantly down, and it's not that common.
And again, we have better treatment like ACE inhibitors, and I think part of it is we rheumatologists are very watchful for that, so we try not to put patients that they have certain criteria, which is antibody or diffuse skin disease, because they can develop very high blood pressure, like to the point that can cause significant damages long term, and kidney failing. So it's very important. Sometimes I see some of our patients with manifestation that they shouldn't be on high dose of corticosteroid, but they come to us with them.
Yes.
So that's something to always pay attention.
Yes. On that, we would like to conclude our section. We're ready for any questions, comments.
And we have also one announcement. We are really happy to announce that with you. So we got approval like 2 days ago for OFAB and nintedanib that is used for IPF, idiopathic pulmonary fibrosis, also approved for systemic sclerosis, ILD. We got approval to use it for patients with diffuse cutaneous systemic sclerosis. They are hoping that it also can help with the skin. So good news about it is it's not immunosuppressive, so we are not too worried about starting to patient the age of COVID. Bad news, it has GI side effects, but regardless, we had that trial and we are happy for the patients that they're hesitant to go for just a skin manifestation on immunosuppressive medication to use a medication that does not suppress their immune system. So we are very excited about that.
Yes, we are.
So we are happy to
take any questions.
Well, thank you for sharing that exciting news about a new study. We will be sure to include information in our newsletter and on our website about how you can learn more. You can also visit the link in the chat that has the link to National Jewish's Scleroderma Research Treatment Center webpage. And now we'll take questions. So please enter them in the chat. I see that we have a few questions already. My tendons are very tight at the ankle and knee. How do I know for sure that this is due to systemic sclerosis?
So first of all, is there any skin thickening at that area, right? If there is no much skin thickening, then I think you would qualify to undergo musculoskeletal ultrasound to see is there inflammation in your tendons, or is there true skin thickening happening there, or is there inflammatory arthritis? As we mentioned in our talk, it's frequently that we get the joint involved and tendon involved with systemic sclerosis, which can get inflamed.
All right. Someone asked you if you could reiterate what you said about covering your ears and nose to help with Raynaud's.
Yeah. So the important thing for Raynaud's phenomenon to keep your core temperature warm, right? So when you go outside in the cold weather and you're covering your hands, you're not covering your feet, you're not covering your ears and nose. A lot of patients, they complain in colder months. In winter, fall, when the temperature is cooler, Raynaud's can happen when they're not wearing their hat. So for my patients, I always recommend, have a set of earmuffs or hat in your bag or purse with you, just to make sure you cover all of this area so Raynaud's won't get active.
So I want to elaborate a little more. Just imagine you want to make your blood warm. So you can lose heat from your neck area because they're vessels. chest area. There are big vessels like aorta. So we want the core warm, and also you don't want cold weather goes inside your nose. So it's good to cover this area and also don't get cold air into your lungs because that just cools down your blood.
Great. And another question is, what kind of exercise or what exercise recommendations do you make with, to patients with systemic sclerosis?
So with the skin manifestation, right, because of the diffuse or limited skin thickening, patient can develop contractures and lose the use of their hands or feet. So when patients stable enough, I like to refer them early to physical occupational therapy. So they work together with the patient to see which activity need to be worked on more, right? And with inflammatory myopathy, muscle involvement, just as disease and overlap with systemic sclerosis, the early rehabilitation and physical exercises are essential to regain that function. Because the longer you are in disease and not doing anything, the more it puts you kind of backwards for rehabilitation and regaining the functionality back.
Yeah, I agree with that. And I think in early disease, it's doable to do lots of stretching exercises. If the disease is advanced, of course, it's going to, especially again, in diffuse systemic sclerosis, that now we are focusing a lot on that because it's quite devastating. Maybe when it's really advanced, it's hard to do that. But I would say stretching, low impact exercises and using like balls for hands and any exercises that you stretch but it's not high impact while they're having like shortness of breath or other issues with systemic sclerosis.
Okay, what do you see?
I had nodule calcinosis lump removed from places that cause discomfort, my back, behind my leg and arm. Are there other options to lessen them or keep them from coming? So we mentioned that there are some medications that we can use, but honestly, there is no like magic medication that I can give them and, they dissolve. But, many patients, for example, they have bone health issues. So we can use bisphosphonate. We can use colchicine if they can tolerate. So the pharmacologic treatments are not as advanced, but we don't lose anything by trying. So, yeah. And improving Raynaud's helps a lot. So if you improve Raynaud's, some of the calcinosis in this area can get better.
And actually some of the calcinosis, especially the dermatomyositis, myositis overlap, it usually develops at the high pressure point. So around the back, right, around the waist where you put the skirt or pants, right? So try not to compress this area a lot with tight socks or very thick, belt or something like that, because this rubbing, local trauma, local damage can provoke calcinosis from developing.
Correct. And it's like, as Mila said, it's good to avoid trauma because, the body response for trauma is to make calcium deposit. Like imagine breast trauma can cause calcinosis in the breast. So is dry mouth an issue with scleroderma? Absolutely. So it can happen in two ways. So one is overlap with Sjogren's syndrome. So by that it means they meet the criteria of antibodies, SSA, SSB. But almost all rheumatologic illnesses cause secondary Sjogren's syndrome. So we normally treat it like Sjogren's. So we have medication like Sevimilin for dry mouth or pilocarpine we can use, and other things like mouthwash.
Yeah, like biotin mouthwash, over-the-counter lubricating eye drops, and there is medicated eye drops which can be prescribed by ophthalmologist for the dryness. And of course, for skin, using lubrication is the key.
So yeah, the patient with systemic scleroderma, they can get secondary Sjogren or primary Sjogren, and they're dry everywhere. So we kind of address that like a Sjogren's syndrome patient.
Another one popped up. Speaking of the mouth, what do you recommend for mouth sores?
So for mouth sores, one thing is to address the dry mouth. So we talked about medication if there's no contraindication. The other one is dental hygiene. So it's good to make sure your dental status goes to see, if dentist at least every 6 months, if it's doable, there's no insurance problem, would be optimal. And then we use magic mouthwash that we can make based on what we see. If we think there is problem with candida, so like a fungal infection of the mouth thrush, we can add niacin to it, or because if they have dryness, they also can get more ulceration. So mouthwash, dental hygiene, using like chewing gum to make sure they're not very dry, or sugarless candies.
Yeah, sugar-free candy. And another thing with the source, right? It would be interesting to see what medication you are on, because some medication can cause the mouth sores, and what immunosuppression are you on. If there is too much immunosuppression, there might be herpes or even candida infection. So the question, have you been swabbed for your mouth sores, to make sure exclude those as a potential causative agents for the mouth sores.